Make sure to click. There we go. Good morning, everyone. Happy Friday. Yay.
Good
It's
morning.
Friday. Good morning. Um, oh, sorry, everyone's in the waiting room. Okay. Good morning, everyone. I hope you had a great week. It is finally Friday. It was a short week, but at least in my experience, the shorter weeks always feel like they go much slower. I don't know if anyone else has that weird feeling too. Um, let's get started. So welcome to the February monthly PATH CPI meeting for Contra Costa County. As folks are joining, if you feel so inclined to put your name, your organization, and I tried to make it, relevant, like a favorite winter activity that you like to do. I was thinking about drinking hot chocolate, but that could be argued that that's not just a winter activity, but just as folks are entering, then we'll go through some updates. We have just a couple of policy updates. We'll hear from Camille at Kaiser. Shelby and I will lead a discussion about a resource repository that came out of the ECM CHW work group. So we'll go into that a little bit more. And then Shelby will lead us through the data and we have some discussion around that. And then there'll be time to take the post-meeting survey and close out. Aaliyah, can you help me with the waiting room?
Can do.
Thank you. It's like it just keeps popping up. Oh, holiday cookie boxes. You'll have to send me one.
It is a labor of love. It takes quite a bit of time, but it's fun to do every year.
I'm sure. Mushroom foraging. That's so cool, Shaneway. Is there a place that you specifically go for that?
Usually in Sonoma County.
Mhm.
Yeah, along the coastal region of Sonoma County.
Do you eat them? Like, are they edible?
Yes.
That's so fun.
Mhm.
I have a good friend who goes mushroom foraging to make dyes for yarn that she makes and then creates like sweaters. And that is like so much more effort than I'm willing to put forth, but I give her so much credit.
That's funny. It's funny to see all these California responses are being warm, going somewhere warm. And I'm sure, Lauren, you could say that, Lauren being from Brooklyn, this is not cold weather, but for us here,
It was
it's cold.
25 in Bryant Park last week, is what I'll say.
That's
Sunny, but
just
25.
doesn't work for me. All right, so as folks are sharing in the chat, we will get started. So we'll start with some updates. First, big update, DHCS has extended the deadline for path-cited round 4 applications to May 2nd. It was originally March 7th, which is a couple of weeks away. It has now been extended to May 2nd. And they're also hosting some path-cited round 4 office hours from 10 to 11 on the following dates on the screen. So throughout March and April before the application is due. And that those so each of those events have their separate registration links, but they're all on the path-cited website, which we will provide for you. And then something we've all patiently been waiting for, DHCS has finally released updates for 4 service definition, or the service definitions for 4 community support services. Those are the nursing facility transition, diversion to assisted living, community transition services, nursing facility transition, asthma remediation, and then medically tailored meals, medically supported food. So those now have new definitions that will go live on July 1st of this year. And then DHCS also plans to release additional service definition refinements for the housing trio in spring of this year as well.
If we can just take a beat on this, so this just came out this week, right, team? So per usual, you'll get your deck. It has Linkapalooza, all the goodies. We're not here to gatekeep, but I did just want to take a beat and ask a question. It doesn't seem like DHCS is gonna do like a big webinar about these updates. Um, with like a quick show of hands or response in the chat, it'd be helpful input for us as facilitators to know if it'd be worthwhile for us to comb through these at a level of detail in a meeting, in an ad hoc meeting, or if folks don't feel like that's necessary. So maybe in the chat, if you're interested in a deep dive on these, just give me like a thumbs up or a yes, and we'll take that into planning consideration for the way that we spend our time. And we won't hurt our feelings if you say no. But we want to be responsive to you all. So just let me know in the chat, thumbs up or a why if you're interested in like a deep dive overview of these updates. Okay. Cool. Keep the chats coming. Just wanted to, Aaliyah and is helping us in particular think about an approach here. So I welcome the thoughts and feedback. So thank you. If you want to say yes, we want a deep dive, or Sarah, love your kind of the purview. If you have reactions, like just put it in the chat and we'll take that as input. Thank you, team.
Thanks, Lauren. Okay, if there are no questions, then we'll continue on, and I'll pass it to Camille at Kaiser for an MCP update.
Thanks, Hannah. A couple of quick updates from me. We can go to the next slide. So as many of you know, Kaiser Permanente contracts for CalAIM services using our network lead entity model. So we're really excited to announce these new kind of provider office hours. So whether you're a current or prospective KP, ECM, CS, or CHW provider, you can now kind of find real-time support through live office hours that happen once or twice a month through our NLE partners. You'll see here ILS has contracted provider kind of office hours the second and fourth Thursday of the month. And then for folks that are interested in serving KP members, they can join the prospective office hours the first Thursdays of every month. They're held virtually, and they're really great spaces to kind of get your questions answered. Hyperlinks for these regular occurring meetings can be found in the slide deck, and I'm happy to drop them in the chat after today or after I'm done talking. We can go to the next slide. And then I mentioned this late last year, maybe in January. We've been gathering info around, how are folks hearing and learning about ECM and community supports. In service to inform the work that we're doing around this ECM pilot influencer campaign. So we have partnered with the Public Goods Project on a social media influencer campaign to expand knowledge and really drive enrollment for ECM and community supports, specifically for the birth equity population and the foster youth population. It launched mid-January, and it's going to go through, I believe, the end of this month. It might go a little bit longer. It's focused on birth equity populations across the state, and then in 2 counties where KP has the largest presence of foster youth, that's San Bernardino and Sacramento. We're also kind of promoting the use of ECM services for that specific population. We're leveraging kind of micro social media influencers as well as community organizations. Our next steps are to really look at the data and see whether or not this has driven community referrals. I hope to present on some of this in the coming months. This truly is MCP agnostic. We're hoping to kind of partner with other MCPs across the state to understand whether or not, even if we're not seeing impacts, has that impacted like their sources of community referrals. So more forthcoming, but if you go to the next slide, you'll see a couple of examples of what our social media posts look like. I can drop them in the chat now if you're interested. They are both in kind of English and Spanish language. The way that we develop the content, I suppose, is we pulled together some packets of like, what's ECM, what's CalAIM, what's Medi-Cal, and got them reviewed by DHCS, kind of sent press packages to our local influencer partners and said, be creative and pull together content that you think would resonate with your audience around, services that you can access if you're a birthing person. Being a mom is hard. Like, how can you access Medi-Cal services, things like that. So I think they're really cool. I've engaged with a couple of them. There are more on the way, but as we get more kind of links available, happy to share those at future meetings. And then I think I have 2 more minor updates, mostly reminders. The first is a general reminder around our ECM and community supports referral processes. In Northern California, we'll accept referrals from any source, even if it's with another managed care plan's referral form. You can call in, you can email. If you're contracted with an NLE and you want to make sure that that member comes back to your organization, you can send that referral form directly to the NLE. The referral form is now updated with that streamlined authorization guidance. So if you're an ECM provider and want to start providing services the day of, no matter what kind of population you're serving, no matter what kind of ECM provider you are serving, there's now kind of streamlined authorization available to you so you can start serving that same day. And then this is just a reminder on the next slide. If you are contracted to serve KP members, you can send that referral form directly to your NLE. And those emails are there. And if you have any questions, feel free to reach out to your NLE kind of contact directly. If there are any issues or if you need additional support, feel free to include myself or the email listed down at the bottom of the slide. And then also highly encourage the office hours to kind of triage any questions around, how can I start serving KP members? Or, hey, I have a question about this like claims issue that I'm having. Those office hours for existingly contracted providers are good spaces. We're working with our NLE partners to identify other ways to support our subcontracted network of providers. And so the office hours is the first way that we're kind of tackling that, but hopefully more to come in the coming months. And that's it for me, unless there are other questions.
Thank you so much, Camille. Yes,
Thanks,
if
Anna.
there are any questions for Kaiser, feel free to put them in the chat or come off mute.
Camille, first, when you said NLE, I was like, Emily? Because we have a colleague named Emily, so I don't know if anyone else is having that reaction.
Emily, I
not
say it very quickly.
It's not just to you, it's just like NLE sounds like Emily. 1, 2, I think just to reach a question and slash maybe a question, request for you to reiterate, but the campaigns are really like, what is ECM birth equity? Like, it's very generic, sponsored by Kaiser, but it's really just a generalized awareness campaign. Is that correct?
Yeah, so totally MCP agnostic. I think you'll see in some of the posts, it's like, hey, are you a mom? Like, being a mom is really hard. Like, do you have Medi-Cal? You can access additional services. They are focused on ECM, but really just driving folks towards these CalAIM, like the suite of resources that are available to them in whatever county that they're based.
Thank you.
Thanks, Camille. Okay, if there are no outstanding questions, of course, you can continue to put them in the chat or contact Camille. But we'll go into some resources to support our undocumented clients. So as a reminder, we host an ECM CHW provider work group, a community of practice. And that group this month in their meeting elevated how relevant, important, and impactful the executive orders have been, particularly on the immigrant and Spanish-speaking populations and communities. So Shelby in the ECM CHW work group worked with the folks whose icons are on the bottom, who were participants in that first work group this month, to create this sort of growing resource compilation, resources to grow your knowledge around knowing your rights about immigration preparation, and then local agencies as well to support clients. And so because this has come up, just as we know, this is imminent and urgent in our communities, we wanted to open space and hold time to have a discussion. Anything that you might want to say, but questions kind of like, what form of a resource guide would be useful for you? How could we scale this to maybe not just Contra Costa, to even outside of Contra Costa? And we really want to know your experience as well. You know, as we know, there have been shifts and adjustments this year due to administration changes. What have been the shifts and adjustments to your approaches in your kind of little p policy and the ways that you serve the community? How is this impacting the way that you're delivering services? So we want to have space for a discussion for anything that anyone might want to bring up.
And as folks are thinking, I'll just offer for continuity from the ECM CHW work group, which again, we had that meeting 2 weeks ago. We pulled together these resources. It doesn't mean it's the end all be all, but thanks to the folks whose um, logos are at the bottom of the screen, they really helped call us into action around this and do something quickly, to Hannah's point. But a few things that were brought up that are running in our heads around this. Obviously pulling this together was like the first crack, something that we think we can do. We are exploring the opportunity to bring in an expert around know your rights for our immigrant neighbors, and thinking about what's the right forum to have that conversation and also what's the right topic. So there's a know your rights if somebody comes into your clinical setting or your CBO. There's also a how do I help my patient, client, community member know their rights because they're in front of me and expressing concern. So we are looking into some experts that can come in and share their knowledge with us. Although again, what questions or what knowledge we want shared, I think we'd love your input on. And then the other item from the ECM CHW work group that we heard that we're taking movement on is we are elevating to DHCS in our, we meet with them where we meet with our third party administrator once a month. We are elevating to them that some of the requirements around meeting people in person might be might put people at risk or might make folks think like it's just not safe. And so I'm going to fall off of ECM in my case management rather than go somewhere or have someone come to me. So that is a conversation that we're elevating at the state level for, I think it's a little P, but it's a bigger P than institutional policy. It's an implementation policy item at the state level. So I just want to honor and share kind of what the ECM CHW work group shared with us and the ways that we're thinking about taking action or providing resources on this topic. And anyone who was a part of that call can jump in if I got any of that wrong, but just wanted to share that those are other things beyond what's on the screen that we're working on and towards. Oh, thanks for sharing, Shane Wei.
Hi, everyone. And thanks, Lauren. I think you did a nice recap of that meeting we had a couple of weeks ago. My name's Amanda. I'm the head of community supports with Zocalo Health, and I did join that meeting. We haven't yet started our ECM services in Contra Costa County. We just got our contract, but in some of the other counties that we're serving in Central California, we're running into individuals not wanting to open up the doors, not wanting to engage. Some of our outreach workers were told that their polos made people nervous because they looked like like state employees or so, like that made people nervous. They didn't want to engage with people wearing like a polo t-shirt. So we've actually implemented, we now have branded scrubs that people are wearing out in the community instead of like a polo or business casual kind of attire. And then we also now all of our outreach staff are wearing uh, like name tags that like big name tags that identify that we are Zocalo, that we're nobody else. Something else that we've just, recently talked about too at a all hands meeting earlier this week was that people are now asking or not wanting to share information because they're scared that we are going to share their data with somebody else. So we are doing some internal trainings with our teams so that they have clear messaging that we are not sharing their data, that we're only sharing data that they consent to us sharing, and only with people that they've consented that it's okay for us to share with. So those are some of the things that we're seeing in our communities that we serve, and some of the ways that we're trying to address those is being more casual in the community, and really making sure that we have talking points about that data sharing, when and how we share data, and that they're really in control of what we're sharing and how and to who.
Thanks so much, Amanda. And I said this in response to Shaneway, your message as well. If there are things you all are developing that are working really well and you'd feel comfortable with us signal boosting that as a resource or a springboard for others that are getting those same questions, Amanda, about the like, I don't want to share data because I'm afraid you're going to share it with me. Please do see us as a conduit to kind of shine a light on what you're doing and scale and spread the stuff that's working. We're going to have to move quickly and move together. I have no interest in reinventing the wheel. So that's an offer always, but especially in this moment, and so appreciate what you brought up around the data concerns and the data elements. I think that's again another thing where Aaliyah's taking good notes for like what can we continue to elevate to DHCS around this stuff. And I think the like what are required data fields and how it can like I think that's a message that we can advise that the state consider scaling right the ways that we're making sure folks are protected and know that they're protected.
Absolutely.
Thank you so much, Amanda.
Yeah, I just would add one other thing that we're doing is in the Central Valley, and I know everywhere, there are quite a few gatherings right now for Know Your Rights, seminars and webinars and things. We have been attending as many of those as possible, dressed in our Zocalo wear so people know who we are, so that we are, we're a trusted community partner. They see us there, um, and able to, help get people connected if they are at those seminars and are needing services. We're helping to connect with them like kind of right on site. So that's something else that we've been doing, is trying to attend and be at as many of those as we can.
Thanks, Amanda. Does anyone have any reaction to the, like, would it be helpful if we put on a CPI sponsored Know Your Rights training? Again, I'm not that interested in reinventing the wheel. If you all feel like there's lots of supports in the community, I don't need that from CPI. Like, we don't need to do it. We've got other stuff we could do. But if that feels like a niche or a good conversation you want to have with your peer ECM community supports providers and the affiliated team, we're happy to make the space. So maybe that's another one you could throw in the chat of like, yes, I'm interested, or no, I feel like we've got it covered.
Thank you so much for sharing, Amanda. Is anyone else, are there other things that are going on in other organizations that you want to share? I see I can't see the chat. Oh, here's the chat. Mm. And if anyone has other resources as well to add to this growing compilation, then we'd love to kind of gather them all in one place and be able to disperse those as well.
And like we said, you have our commitment that we'll be elevating these like lessons learned, best practices, and potential little p bigger but little p policy call to actions in this moment. So thanks for sharing what's going on, and know that we're going to do what we can on the other side. Cool.
Okay, well, and of course you can keep adding things in the chat, but we will continue on. And I'll pass it to Shelby to walk us through all of the beautiful data we have.
Thank you. Hi, everybody. Let's go to the next slide. For those of you who might be new to the room, I think I see some new faces. In our Path CPI Collaborative, we try to share out data on ECM and community supports utilization as frequently as possible. And we try to have these conversations to help guide our direction as a collaborative in trying to improve CalAIM implementation in Contra Costa County. So in December, which was 2 months ago, kind of hard to believe, in our December PAT CPI meeting we had in person, we had an activity for the room where we asked you all what you would hope 2025 would look like for ECM and community supports utilization for Contra Costa County. We had graphs on the wall with the data that we had available at the time. So looking at sort of the numbers from 2024 that we had available, like what did we project or what did we hope to achieve over 2025, which is now. So keeping that in mind, you all did put dots on our flip charts and hope to see that our, ECM utilization would be at about 9.5 thousand people enrolled by the end of Q4 2025, and about 4.5 community supports utilized by Q4 2025. So keeping that in mind as we go forward, not just for today's conversation, but also for the whole year, because this is essentially what our overarching goal is, right? To improve access to both ECM and community supports for those who are eligible. And hopefully we'll be able to see how our utilization tracks based on our hypothesis, our goal from December. So let's go to the next slide. We'll start with ECM. Thanks to our MCPs, CCHP and Kaiser, who provided some of the data for that we were able to sort of track over quarter by quarter. You can see here we have the number of members who have received enhanced care management in Contra Costa for all populations of focus, quarter by quarter. We don't quite have Q4 2024 yet, hoping to have that shortly, and when we do, we'll present those numbers to you. For those of you who are seeing these graphs for the first time, the yellow are the number of people enrolled in that quarter, and the blue is about 5% of the total Medi-Cal enrolled, the total number of Medi-Cal managed care enrollees in Contra Costa for that quarter. And we do 5% based on an estimate that about 3 to 5% of all Medi-Cal members would be eligible for enhanced care management. This number is an estimate from DHCS based on their calculations. It might be higher or lower for Contra Costa, we're not sure, but you can kind of compare the two numbers across the board. And then you can also see our 2024 AIM statement. So our goal for 2024, which is that red line, was that by the end of Q4 of last year, we would have about 6.6 K enrollees. So we don't have Q4 data, but that was where we hope to end up at the end of last year. If we want to go to the next slide, and if you have any questions, by the way, I know I'm going through these numbers kind of fast. Please feel free to interrupt me or put something in the chat. These graphs will be shared with the slide deck at the end of the meeting. So you'll have time to review and look at these yourselves. So we decided to try to do a little bit of a breakdown of those larger aggregate numbers into specific populations of focus that we thought might interest you all as a collaborative. So looking at children and youth, so all the populations of focus for children and youth aggregated together, the birth equity populations of focus, or so both adults and children under those the birth equity population definition, adults and children transitioning from incarceration, and adults managing homelessness or experiencing homelessness. So we looked at the enrollment numbers across quarters 1, 2, and 3 for last year, as well as the estimated eligible that we sort of did some math about how many eligible people we estimated in the county would be eligible for each of these populations. But looking at these numbers, I'm curious, does any of the utilization data here that we're showing surprise you about how many people are enrolled or utilizing ECM? We're looking at the estimated eligible numbers. I mean, as in we and Lauren, did some pulling from other data sets that we had access to calculate those estimated eligible numbers. Do you feel that those are the right sort of numbers? Do you think from your experiences as providers in the county, does that seem to track with your own estimates?
And I'll just jump in. Everybody loves a good footnote, so I'll provide some annotations on my footnotes, which make a proper data analyst like Shelby nervous. But as I was looking at these, rightfully so, Shelbs, and as I was looking at these numbers last night, I was like, I don't know if this is good or not. So what's the best we can do? So I'll provide just a little bit of voiceover on kind of the sources of estimate eligibility. The children and youth estimate eligible presumes that Contra Costa County has the same distribution of Medi-Cal members as the state overarching average. So that number represents the 36.8%, which is the number of California children on Medi-Cal, against the 5% threshold that Shelby offered, that we know is kind of the number in Contra Costa County of Medi-Cal lives. If that number is our baseline, we're at 28% saturation for the children and youth population of focus, with some modest climbing between Q1 and Q3 of last year. Birth equity population of focus. A reminder that this one is specific for birthing people who are Black, American Indian, Alaskan Native, and Pacific Islander. And those are the kind of census headers that we're looking at. So it is quite a small population. This number is probably the one that I did the most math magic with. But the CDPH does have a birthing public data set. The data set looks at 2 years or 3-year increments, right? So had to do some, annualization, yada, yada, blah, blah. But if we do the math the way that the math is kind of described here, and we look specifically at those three race and ethnicity eligibility definitions under birth equity, where it's about like 179 folks that would be eligible. Again, these numbers are the most estimates that could be estimated, but gives us a sense of a threshold of like, are we at 49%? No, but you know what? I feel confident saying we're above 5 or 10%. And that's, I think, the directionality we were interested in seeing. Also, a reminder that these are populations of focus that towards the end of last year, we heard that there was interest in double clicking on. So if there's other populations that aren't represented on this graph, or if we think we can narrow from these 4 populations to less, we're open to that. I wasn't able to find a good estimate eligibility for folks that are transitioning from incarceration. But for adults managing homelessness, I was able to use the 2024 point in time count measure to be eligible for this population of focus for ECM. You need to be both HUD definition of houseless or at risk of homelessness and have at least one chronic condition. So the point in time count estimated that 83% of folks self-identified as having a like a severe health condition to some degree. So this represents 83% of the folks in Contra Costa County that were identified as without homes in the point in time count in 2024. Again, is that number accurate to a T? No, but I feel pretty confident that we're at the 7 to 10% marker and not the 50 to 60% marker in that population of focus. The one other thing I'll provide here, we're providing a lot of voiceover because this is the first time we've had this level of data for this county. So hopefully that's exciting. But you'll notice that that last population of focus is specifically adults. That's because children that are managing homelessness are represented in the children and youth category in row 1. So just offering that. I think all of Shelby's questions stand. I think we're curious if this resonates, if this is consistent with kind of your experience, if there's any surprises here. But again, wanted to provide some voiceover on where and how we're manipulating the data, and also to let you know that I know that our estimates are wild, but they are directional, which I think is the intention.
I had a quick question, mostly just to confirm my understanding. So, I know you mentioned the homelessness row. That last one is kind of exclusive to adults. Is the birth equity population of focus? I know that that is also split by adults and children. Does that kind of, do the portion of that roll up into the youth, the children and youth row above it?
That's a great question. Shelbs, do you know? I could
Yeah,
say for the estimate, it's focused on the birthing person, but for the DHCS data, Shelbs.
DHCS breaks it down. When I think Lauren, you created this graph, but usually when I have the two like charts up, I split it up as well. And we ask MCPs as well to provide that data separately. So I believe this is the sum of both. But it's low, right? For regardless of it's both adults and children, adults only, children only. It's a very low number compared to these other populations we're looking at. So,
Yeah, I'll say from Kaiser's side, I mean, from our perspective, our increases for community supports have been a lot less gradual. Like they've grown a little bit more between quarters. I think that the moving the needle on ECM has been a little bit harder. Um, I think we're paying a particular focus on that birth equity population in children and youth. There are different focuses across all the different counties, but in Contra Costa, that's something that we're kind of taking into consideration. And we've seen a little bit of a change, and we're thinking about kind of a broader statewide strategy around kind of how to increase access to birth equity kind of services for Medi-Cal members. That outreach pilot was just one of, I think, a couple of things that we're thinking about. But this rings true from like a managed care plan perspective, I think. But again, I think we have less. I think we have around 15% of the managed care members in the county.
yeah, thanks for sharing that, Camille. I think that, I mean, yes, Kaiser has a really small sliver of Contra Costa share right now, but I think that also the pattern rings true, at least from what I've been looking at, like across the Bay Area, in terms of like utilization for birth equity. Like it's low for everybody. So hopefully additional awareness, things that you're doing like on the MCP side, supporting providers, doing your social media awareness campaign can help bring those numbers up. Let's go to the next slide, actually. We had some discussion questions. I'm curious, we picked those, you know, 3 populations, or we picked those populations of focus. But are there any other populations as a group that you would be interested in us monitoring for ECM? Like there's definitely others out there, but we picked some that we thought would be good priorities for collaborative. Or are there other data sources that you have access to on your own ends that aren't just, the public data sets we're looking at from DHCS, from CDPH? Curious if there's anyone on your ends doing data analysis for your own organizations, how you're tackling that challenge. Well, if you guys ever find any data that you would be willing to share with the collaborative, I think that would be really helpful for us all. Happy to, set up time to talk about data as much as possible. It's my favorite thing in the world. So, this isn't like closing the door on this conversation. We really value data transparency as like one tool that we can use as a collaborative to help, CalAIM implementation in the county. So if there's ever data that you would like to share with the collaborative in these meetings, please let us know. The last question for ECM at least is we have the new ECM referral standards and template was live as of January 1st of this year. I know it's only been like a little over a month since that has happened, but curious how you would anticipate those new standards to impact ECM utilization rates for this quarter. Or if anyone is experiencing the impact right now, would want to speak to their experiences so far.
I can quickly chime in and say, I know there's the standardized referral form. All the managed care plans were supposed to kind of push out their standardized ECM referral form based on DHCS guidance that should be live for all managed care plans as of 1/1. There's also the streamlined authorization guidance, previously known as presumptive eligibility. I can say on from Kaiser's perspective, or what Kaiser is doing, and I think Anthem and HealthNet and some of the other MCPs are doing the same. When DHCS released the guidance, they were really specific on like who would be eligible, like based on like the types of ECM providers and the types of populations of focus, and you had to match them up. I think a lot of the managed care plans realized that that would be operationally really challenging. So like writ large, if you are an ECM provider, you are eligible for streamlined authorization. I think ideally, the hope is that it would increase referral rates across all populations of focus. I mean, it's still relatively new. And as folks kind of test out or use the streamlined authorization processes, for Kaiser or for honestly any other MCP, would love to hear about like how it's working and if you're facing any challenges. The goal obviously is to increase utilization rates for ECM. I'm not quite sure if we'll see that honestly in Q1. I think the processes are a little bit disjointed and we're all kind of trying to figure out what this will look like. But yeah, this is all to say, if you have any feedback, would love to hear it. If I were to guess, I think we're going to see maybe some changes in Q2.
Yeah, thanks for sharing that, Camille. Yeah, to any of the ECM providers who might be actively doing referrals right now, curious if anyone wants to share their experience about the new referral standards, the new streamlined authorization process, not just for Kaiser, but also, for CCHP providers in the room, if anyone has anything to share.
I'll just say that I think there was like a thought that the updates to the referrals might reduce some of the manual referrals we were seeing, because it's really clear, like you have to attest if you're submitting a referral to various eligibility requirements. But I just was glancing at some of the data like that we've had around our manual referrals, and I haven't seen like overall like a huge decrease yet. I don't know what that means. I also think some providers are just saying, I want to get them an ECM, and I'm going to say, yes, they qualify, even if maybe they don't fully because they're not, I mean, I don't know if they're always checking, for example, like, I think like, again, like things like, are they checking the HUD definition and making sure people really qualify under that specific definition? I don't know that they're actually going somewhere else to look up those kind of requirements prior to submitting referrals. So I don't know. I don't think we've noticed too many changes as of yet.
Yeah, thanks for pointing that out, Jenna. And I mean, that could also go to Camille's point. We might not see any impact, at least in Q1. I mean, it's still so early since these changes have rolled out. Maybe they'll take a couple more quarters. Maybe it doesn't have a huge impact. Like it's really up in the air right now. But that's a really good observation that we can take note of. That yeah, you haven't experienced any significant changes, and maybe that's something we'll keep an eye on. Does anyone else have any comments or thoughts to share about any of these questions before we move on to community sports? Okay, let's move on to the other half of the data. So now we're going to look at sort of the equivalent of community supports, number of community supports utilized in Contra Costa County. You can see here a very similar graph to the one I showed in ECM. For ECM, we had about a little over 3,000 community supports utilized in Q3 2024, hoping to have the Q4 2024 data shortly from both MCPs, so we can show that graph when we have it. We achieved our aim though. So 2024, we had set our aim out as, having 2.8-ish community sports services utilized by the end of Q4. We will well surpass that goal. So, I mean, we got to celebrate our wins when we have them, guys. So that's really great to see. And so when we, again, sort of going back to that first slide that I was talking about with our 2025 goal, when we start having or receiving the 2025 data, we'll also have the line to sort of reach towards for that. But just wanted to clap ourselves on the back when we have that.
And Shelbs, as a reminder, this one, community supports, is not unique individuals, unlike ECM, right?
Yes. Thank you for reminding me. Yes. So for community supports, we are pretty explicitly saying that this is not the number of members who utilized community supports, right? Because when we receive the data from MCPs, when we're looking at data usually presented from DHCS, typically it's not deduplicated, right? Because people can utilize multiple community supports at once. So when we receive numbers and looking at it at this aggregate level, people can be accounted for multiple times if they're receiving multiple community supports.
And Sarah just put a good question in the chat, I think specific to MTM, but there are instances where this is true elsewhere with community supports, where you're enrolled in a program and you get a service for a certain period of time. Shelves, my understanding is it's counting that enrollment count.
Yeah, so I believe, at least the way that I'm reading the definition from the DHCS websites, is that if somebody's enrolled in, for example, an MTM for during quarter one, regardless of how many times they're receiving, groceries or they're receiving a meal box, they're counted once in that period of a quarter. So I hope that answers your question, Sarah. But yes, so if they're receiving MTM and they're receiving, housing transition support, they would be counted twice in that quarter. Does that answer your question? Let's move on to the next slide. We have a breakdown. So I know there's some MTM MSF providers in the room today, so wanted to call out, we have the data for MTM utilization. So looking at this graph, it looks like a pretty nice, increase quarter by quarter. We ended in Q3 with about 1,600 community support services utilized in Contra Costa. I'm gonna go to the next slide as well. We did the breakdown as well for the housing trio. So the three sort of core housing community support services, housing transition navigation services, housing tenancies and sustaining services, and housing deposits. Looking at this data as well as the MTM chart from the last slide, curious if these utilization numbers are surprising to anybody, or if they track with with your experiences as providers, or if there's any sort of interesting call outs people want to comment on.
Jenna put a specific question in the chat around a push for a request of fresh versus frozen meals for MTM referrals.
Sorry, I know that's not really relevant to the data, but MTM came up and I was like, wait,
Yeah.
this question was posed to me this week.
Well, it might come up though, because if that's the answer, that could impact the number of eligible referrals or eligible service delivery.
Basically,
So.
when the response from CCHP, which I can elevate this question to them, if any of the MTM providers know or have heard this, that there was like a question back, like, why did you select this vendor when we should be kind of prioritizing it was either like groceries or fresh food versus, and wanting justification.
Yes, we heard that from Peja as well.
Okay.
That essentially Contra Costa is pushing for, if someone can cook, they should cook.
Okay.
They should get groceries instead of meals.
Thanks, I'll update our PCM
But
stuff.
if you were able to like justify a reason why microwavable meals would be better for someone who's not, you could just put that. Is there somewhere to just say that?
Yes, if they can't cook, they should get meals. Yeah, no problem.
Mhm.
If they can
Okay.
cook, they should get groceries.
But you don't want to cook. No.
Too bad. Yeah, we've heard that as well, which is great news in my opinion.
Are there any other questions that were just floating around? Doesn't have to be related to the data we just had, but
I guess just around this data, I'm not surprised the housing deposits are so low, and not even because people aren't eligible or needing them. It's just like an ongoing, I think deposits are an ongoing challenge.
do you want to maybe speak to?
Well, I think it depends on how someone's bundling it. So like, for example, we provide housing transition navigation and tenancy, and we don't provide deposits. And so there's like this challenge around getting someone a deposit and transferring them to a different provider to provide navigation, because there's not really providers that will just provide deposits. So, and again, that's just why I guess this data does not surprise me that the numbers for deposits are so much lower.
Yeah, thank you for sharing that, Jenna. Did anyone else have any observations about either the housing trio data or the MTM data? And we can go back to it if you need it, but I'm going to open the floor for that. If not, we can go to the next slide. So had some additional discussion questions to me to ask you all. So why do you think that the housing transition navigation numbers had such high utilization rates compared to the ECM utilization, going back several slides, for those managing homelessness and the other housing trio community supports? do you think there's a disconnect?
I think anecdotally,
Mhm.
it doesn't surprise me totally in that there are some clients, like we'll even get in for ECM, for example, who are like, I don't want to talk about anything but housing. So if somebody is really only focused on housing and does not want to address anything else, then, from my perspective and what like I would encourage is like, then housing navigation is a better fit than ECM, because if you're not willing, like ECM is broader coordination. So if you are only wanting to address at that moment housing and you have no interest in even talking to someone about other things or getting help with coordinating care, then I think that housing navigation actually makes more sense for that in that moment.
Yeah, absolutely. I think that could very well be why. A lot of people, like, I mean, they have their own priorities, right? Housing being for many, many people in the Bay Area and Contra Costa, like the first one. So, yeah, thank you for sharing that, Jenna. For anyone else providing housing services, not necessarily the housing trio, but it could, ECM, any sort of housing support in Contra Costa. Has there been any sort of experiences with trying to refer people into one of the housing community supports or for ECM? Great. I got sidetracked with the time. Totally was not paying attention to the clock. Let's go to the next slide. I think that was the last data slide that I had to go over. But again, we'll have these graphs for you in the follow-up, so you'll have all this information. And then for those of you who can access our Google site, these will be posted up on our Google site for Contra Costa within the next week. So you'll have all the updated information in various places. But thank you, everybody. I'll pass it back to Hannah.
Thank you, Shelby. I think the data conversation is really important to have. So I don't think anyone minds about the sidetrack time. Okay, so we are 2 minutes away from our end time. So just to close out, Aaliyah, could you launch the poll, please? So please take our feedback survey poll. And as you're doing that, just a reminder of some upcoming events. Next week, Tuesday, the 25th, we are hosting a CalAIM Curious, which is really just an overview of what is CalAIM, what is ECM, what are community supports. On the 26th, we are hosting a CalAIM 101 that is specifically focused on folks that could be referrers for the children and youth population. So that is a more specific CalAIM specifically for children, as I said. Monday, March 3rd will be the next ECM CHW provider work group. The 14th is our in-person Food as Medicine CalAIM work group symposium. And then the 21st is the March Contra Costa meeting. And then quickly, just some other upcoming events. HC2 Strategies is presenting their own version of CalAIM Academy, specifically for hospitals and health systems. It's a series of 6 webinars. There's a flyer for more information in the registration link. And then again, as I mentioned before, DHCS is hosting office hours for the Path-Cited Round 4 application. The link is there to register, and those are the dates that they will be hosting those office hours. And then there's a bunch of data in the appendix for you. But Lauren, is there anything else to close?
I don't think so. I'll just say y'all happy month 2 of year 4 of 5 of this program. We're really conscious that it is year 4 of 5. So some of those activities like the CalAIM and Food as Medicine Symposium are conscientiously starting to think about the intersections of CalAIM and the soft place to land on the other side for service providers and for the people that you all serve. So you'll see more of that as we get deeper into year for so we can steward continuity of services. But yeah, thanks for joining us today. We hope you like to dumpster dive in the data that we gave you in the deck. We will make sure to send that out as we always do. But I hope everyone has a good day and happy Friday. Happy almost end of February. What is time?
Thanks all.
Thank you.
Bye.
Happy
Bye,
Friday.
Thanks so
folks.
much, everyone.
Thank you. Bye.